Northampton Area Pediatrics. And as you can see in the screen now, excuse me, we would like to record this session at the for the first half of it, which will be some presentations by the speakers. And then we will allow time at the end, plenty of time to ask questions. And if there are any individual questions that might be personal and don't want, we will be stopping the recording. So if you have any of personal questions that you want to ask, you can save them to the end. It's a pleasure to be here this afternoon. We're talking about a very important subject about adolescent substance use. And I'm very happy and pleased to introduce some people who will be helping me with this presentation. The first person is Kit Bayer. She is a behavioral health clinician here at Northampton Area Pediatrics. She's a licensed social worker. She also is a behavioral health specialist at the ASAP program, which is the Adolescent Substance Use and Abuse program at Children's Hospital, which is a leading organization and program of the country in dealing with this problem. Also with us is Dr. Caroline Johnson. She is the Public Health and Data Specialist at the Department of Healthy Families and Communities at the Collaborative for Educational Services. So thank you, Kit and Caroline, for joining us today. We've been doing these workshops for many years now, and I hope and idea is that be able to cover topics in a little more detail. These are topics that we think and hope that parents are interested in. And we can do this only in this kind of setting, whereas during the office hours, we often can't delve into as deep questions and concerns that parents have. So if there are other things and topics that you're interested in hearing, please let us know, and we will try our best to develop a program around that as well. As far as the programs that we do have set already, I just wanted to let you know that this is a list of the ones that we have coming up for this academic year. And I'd like to pay attention to November 13th is one that for adolescents would be particularly important, I think, is depression and isolation. And that'll be run by another behavioral health clinician in our office, Adam Blackburn. Today's program is going to be talking about substance use. And I kind of termed it the what, why, and what of this issue. We're going to start by having Dr. Johnson talk to us about what are the teens using in our area, Hampshire County in particular. She has excellent data showing the recent usage of teens and middle-aged students. So we get a sense of what it is that these children and teens are actually using. She'll then send it back to me, and I'll talk a little bit about why this issue is so important and why it's important for adolescents in particular, and why substance use in adolescence is different than it is for adults, and how substances affect their brains and their bodies is different. And that's always important to keep in mind when we think about how we should and can help adolescents. Then I'm going to send it back to Kit, who will talk about what it is that we can do to help teens who are using these substances. I do encourage, this is a relatively small group, and I hope that people can be very comfortable in asking questions, things that you have questions about. If it's related during the time that we're presenting, go ahead and use the chat function, and we'll try to monitor that. If there are questions that have general things that you'd like to talk about, just wait until the end, because we will have plenty of time to do that. So I think we will go ahead and get started with the program. And Dr. Caroline Johnson, maybe you can, if I'll stop sharing the screen and send it back over to you, and you can tell us about what Hampshire County teens are doing and using.
That sounds great. Okay. Okay, can everyone see the presentation and hear me?
Yes.
Okay, great. So I'm going to talk a little bit today about teen substance use rates right here in Hampshire County. And these are based on results from local youth survey data that I collected this past spring of 2022. And as Dr. Schwab said, my name is Caroline Johnson, and I'm a researcher at SPIFFy, which is within the Department of Healthy Families and Communities at CES. And basically, SPIFFy is a youth substance misuse prevention organization based in Northampton, and we do a lot of different things. And one of the primary buckets of work that we do is collect data on youth substance use and related outcomes and behaviors. So before I dive into results and start talking about youth substance use in Hampshire County, I just want to take a minute to give an overview of the survey tool we use and the specific questions that are the primary basis of the presentation. So our youth survey is called the Prevention Needs Assessment Survey, or PNAS. And as I said, it measures substance use and also risk and protective factors for use, like mental health outcomes, across the county. And typically we administer the survey every other odd year, and we ask all 8th, 10th, and 12th graders throughout the county to complete the survey. Obviously, 2022 is not an odd year. And due to COVID-19 and concerns about youth substance use in the wake of the pandemic, after quite a long time of isolation and, now things opening up again, we wanted to administer an off-year survey in the spring of 2022. So when I'm talking about youth substance use rates, it's based on these countywide data from this past April. And in this past iteration of the survey, we had just under 1,500 students complete the survey. So to assess past 30-day substance use, we asked students the following questions. So during the past 30 days, on how many occasions, if any, have you, 1, had alcoholic beverages, 2, used marijuana, 3, smoked cigarettes, and then last, vape nicotine or used e-cigs. And for each of these different substances, youth responded using response options that ranged from never to 40 or more times. And responses, this is kind of standard practice. We group them into one of 2 categories: no use and any use. So when I present results on the following slides, the percentages typically represent the percent of youth who reported using each substance at least once in the past 30 days. So before what I'm going to do is I'll talk about all those 4 different types of substances specifically, but first I want to make some cross-substance comparisons so we can get a feel for what substances are more commonly used and which substances are relatively less used. And when you look at it, you can see that alcohol is the most commonly used substance, followed by cannabis and nicotine, in particular vaping nicotine. And then smoking rates are a lot less common. So about 1 in 4 students report drinking in the past 30 days. About 1 in 6 are using weed, and 1 in 7 report vaping. And then it's a lot lower for cigarettes. It's fewer than 1 in 20 youth who are reporting smoking. And this is the average across all grade levels. So this is 8th, 10th, and 12th graders combined. So when I start talking about each specific substance, I'll break it down by grade level, because you'll see there are really big differences depending on what grade you're looking at. So I want to point out that, even though alcohol is the most commonly used substance, it's also the most infrequently used. So on this slide, I'm looking at frequent and very frequent use of substances. So looking at using a substance on 6 or more occasions in the past 30 days, and then 20 or more occasions in the past 30 days. And what you can see is that teens who report using things other than alcohol, in particular cannabis and nicotine and tobacco products, they're using these substances a lot more regularly. So just as an example in this chart, you can see that, just under 5% of youth who report drinking in the past 30 days did so very frequently. But then when you look at cannabis and nicotine, just about 1 in 3 teens who reported using these substances did so on at least 20 occasions in the past 30 years, or sorry, 30 days. So to get a full picture of teen substance use, it's not just whether or not kids have used, it's also the extent to which they're using that matters too. So now getting into each particular substance, looking first at alcohol, since it's the most commonly used. You can see that that basically 12th graders are a lot more likely than 8th and 10th graders to report drinking alcohol. And this general pattern of 12th graders using substances at higher rates, this holds true across all of the different substances I'm going to talk about today. So with alcohol in particular, over 4 and 10 12th graders report drinking alcohol in the past 30 days, compared to about 2 and 10 10th graders and fewer than 1 in 10 8th graders. So especially when looking at 12th graders, drinking is pretty common, but again, it's something that kids aren't doing every day or on a routine basis. It's not a habitual behavior. But nevertheless, when teens are drinking, a lot of teens report drinking a lot on any one occasion. So across grades, 1 in 8 teens report binge drinking in the past 30 days. And when you look at 12th graders specifically, it's 1 in 4. So even though drinking isn't necessarily a regular behavior among teens, when they do drink, a lot are drinking heavily, and that has immediate implications for their well-being. And I think this is reflected in the stat I have presented here. We asked youth about consequences of drinking, and basically 1/3 of students who reported drinking in the past year also reported that they got sick to their stomach or threw up after drinking. Okay, so now turning to cannabis. Same general pattern here. So 12th graders are a lot more likely than kids in earlier grades to report using cannabis. And about 1 in 3 12th graders report using cannabis in the past 30 days, compared to about 14% of 10th graders and 5% of 8th graders. We also asked teens who use cannabis how they're consuming cannabis. There are lots of different ways that you can consume cannabis these days, so we thought it important to ask that question. And it turns out that the majority, many youth who use cannabis report that they smoke cannabis, and large portions also report vaping it, consuming edibles, and dabbing cannabis. And for any of you who aren't familiar with dabs or dabbing, dabs are basically very high concentrate waxy forms of cannabis, and dabbing refers to inhaling vapors that result from heating dabs to very high temperatures. So dabbing gets people very high very quickly. And then I just want to point out, there are also a fair amount of kids who report drinking cannabis beverages like seltzers that contain the product. So there are lots of different ways that kids are using cannabis these days. And another factor to consider regarding teen cannabis use is the potency of the weed they're using. So potency refers to how much THC is in cannabis products. THC is the psychoactive component of cannabis. And we care about high potency products because the use of these high potency products is linked to particularly negative outcomes, such as dependence and psychosis and structural brain changes. So we included some additional questions on our survey about potency. And we asked kids who have ever used cannabis if they know about the potency of their products, the products they use. And basically half of teens who have ever used cannabis have little to no awareness of how much THC is in the cannabis they use. And of the kids who do know the THC content or potency of their products, nearly 6 in 10 teen cannabis users report using cannabis with greater than 20% or 5 milligrams of THC, which meets the definition, or at least some definitions, of high potency products. So basically, a lot of teens in Hampshire County are using cannabis, and many are using it regularly. And furthermore, many are using high potency products. So that's not a great combination from a health perspective. And we asked a similar question regarding acute consequences of use of cannabis, and just under a third of students, similar to alcohol, kids who report using cannabis, about 1/3 felt extreme confusion or anxiety, hallucinated, or even felt nauseous or threw up after using cannabis. Okay, so next, vaping nicotine. It's the same general pattern here. So you can see that 12th graders are the most likely to vape, and 1 in 4 12th graders report doing so in the past 30 days. Whereas just over 1 in 10 10th graders and 1 in 20 12th graders report doing so. And then finally, with smoking, you can see the same general pattern here, but you can also see that teen smoking rates are low. Public health campaigns have done a great job over time getting the message out about the harms of cigarettes. So we can see in general, smoking rates are pretty low. And the average across all students is about 4%. Among 12th graders, it's a little higher at 7%, and 8th graders, it's even lower at 2.5%. And I think that's it. So I will hand it back over to Dr. Schwab.
Great, thank you very much. Certainly very sobering statistics in terms of numbers and trends and tendencies. Does anybody have any questions for Dr. Johnson before about those statistics, about the frequency and the types of use in our community? What I think I will do then is to share my screen. Wait a minute. I have 2 now. I think I'll go with that one. Let me try to do this, and and you can see that, I hope. Are we good?
Looks good.
Okay. So let me go on to talk about the why. Why is this important? And I'm going to go through this relatively quickly, because I think a lot of people may have heard this already and have the ideas of the things I'm talking about. But I'm always, if there are more things that you would like me to talk to center upon, by all means, let me know. But what I'd like to talk about is very briefly how the brain of people develops, why the adolescent brain is different than yours or mine. I'd like to then talk about how substance use affects the clinical aspects of what happens to adolescents who are using substances, and then the consequence of a couple of the more common substances that teenagers are using. The first thing I want to just define something a little different. What we've been talking about generally is substance use, but there's there's also something called a substance use disorder. And that's a medical diagnosis from the DSM-5, which involves some criteria of these things that I've listed here. In order to have a disorder of substance use, you have to have at least 2 to 3 of these features, and that would be considered mild, and then there are moderate, would have maybe 5, and then severe. What are these features? There's a tolerance, that is, the more you use something, you need to use more and more in order to get the same effect. Not being able to stop or manage on your own. When these substances interfere with your work, home, or school environment, giving up important social or recreational activities. Often people with substance use disorders might stay at home and just be secluding themselves using the substances, causing problems with relationships. This is common in substance use disorder. Both family and friends relationships are often disrupted by the use of the substance. Placing yourself in danger or others in danger, driving, for example, would be an example, is common when you have a substance use disorder. Cravings are often occurring when you need that substance and you crave for it and can't overcome that craving. And then if you try to stop the substance, you develop withdrawal symptoms. Now, again, some adolescents have one or two of these types of features while they're using substances, or maybe none, but that doesn't mean that they're not having problems with the substance. And I want to make sure that we understand that the use of substances in teenagers is not, any substance is not good. And I'll explain why that is. And I also want people to understand that the way in which we can help teenagers, they don't have to have a substance use disorder to seek help and gain help. So any adolescent who is using substances can get help in our office and help in general, and should. So one of the things that this slide shows is that substance use disorders are often not diagnosed accurately. And there's a large percentage of teenagers, about 4.5% of adolescents are thought to have a substance use disorder, yet only about 8% of them actually receive treatment. So here's what we're talking about. We're talking about the difference, the growth of children, and this is my niece, who is from infancy or as a baby moving forward into teenagehood. And while it's obvious how people grow physically, what's not so obvious is how their brains are developing. And even though here somebody who is 18 maybe has the size and the look of an adult, inside the brain is anything but that. And what we know is that there's a critical period of brain development in adolescence, and then that people's brains continue to grow up until age 24 and 25. Even now, people are thinking later if you have certain conditions such as ADHD. So this is a short, just a brief description of how the brain develops, and it develops from the back to the front. And during these periods of brain development, there are critical times where, as that brain part is developing, if it's introduced to substances, it can be damaged. As toddlers, the cerebellum is responsible for motor development, and then they develop emotions. So we know the terrible twos and toddlers have difficulty with maintaining their emotions. And they develop things such as separation anxiety, which is all due to the fact that that part of their brain, called the amygdala, is developing. And then there's a very important part of the brain that develops next called the nucleus accumbens, which is the pleasure center of the brain. This is the part of the brain that when stimulated, you feel reward, or when you get reward, it gets stimulated. And it's a feel-good part of our brain, so that if somebody says you've done a good job, that part of the brain lights up. This is also the part of the brain that lights up when you use substances because they feel good to some people. So this part of the brain develops before this part. And this is the prefrontal cortex. And this is the part of the brain that's associated with executive functioning, meaning planning, organizing, paying attention, making decisions. And if that part of the brain isn't as well developed as the pleasure part of the brain, then decision-making about substances is often fraught with problems. And this is another schematic of showing the difference between the limbic system, which is that emotional part of our brain, and the prefrontal cortex, which is the thinking part of the brain. So the limbic system is like a green light. Go, go, go. I like that. It feels good. And the prefrontal cortex is saying, wait a minute, if you do that, what's going to happen in the future? What are the consequences of those actions, such as driving? If you take a substance, your thinking part of the brain says, wait a minute, you might be impaired and you might not be able to have safe driving. But if those things are not in balance, then you start to be using the nucleus accumbens as the driving force of what you do. So here's a graph showing that difference between development of the pleasure center, the nucleus accumbens, and the prefrontal cortex. Eventually they meet up, but during this critical time when they are not, it's common for people to make, for teenagers, to be making mistakes and going with what feels good without understanding or really acknowledging the consequences. So when substances are used before the prefrontal cortex is fully developed, then cravings can become uncontrollable for certain substances or drugs. And once cravings have started, the brain ignores the rational thought of the prefrontal cortex, and the person no longer has control. And this is why we see it's more common for people who introduce substances into their body at younger age, they're more likely to become addicted. We also know that the brain, if it's developing and and substances are in your blood system and around your brain, it interferes with the development of your brain. Now, excuse me, I want to just spend another minute going even lower down into the anatomy, and that is what's happening from the neurons. At birth, neurons are what our brain cells are called. And at birth, there are very few of them. And then as we grow and develop and learn, do things, there's huge development in the number of neurons. But it's very scattered, and it's very disorganized. So that there's a process called pruning, which occurs during teenagehood, where these neurons become larger, they become more efficient, and we take away those ones that are not needed. This is kind of used as an analogy of a super information highway. You're developing a super highway from maybe many country roads. And if substances are in your brain during this critical time of development, then it can interfere with the development. So now, that was quick, but we could get into it, but more of it, but I just wanted to get into more of the clinical aspects of what does this all mean? What are teens, how does these substances affect them? So let me start with this one. This is showing at the age of introduction of these substances, how it can influence the chances that you become addicted or develop a disorder. So on the left, you can see that if teenagers are starting to use alcohol at a very young age, 13 or 14, there's almost a 50% chance that they will develop an alcohol disorder, alcohol use disorder. And it goes down with increasing age. You can see the same kind of data for marijuana. And while the numbers are not quite as high, they're still very significant. So that teenagers who are starting at 13 or 15 years of age to use marijuana, they have a 17 to 16% chance of developing an addiction and a substance use disorder from that substance. Here's a list of other things that are correlated with the use of substances in adolescents, because they're not able to use the prefrontal cortex as well as older people, so that they're more likely to develop injuries while they're using substances, or emergency room visits. Violence can occur because they can't control their impulses. Sexual assaults and unprotected sex resulting in sexually transmitted diseases or unwanted pregnancies. And ultimately, we see an increase in school failure as well. I wanted to show you something. This is from the SPIFFy data as well. This is from teens in Hampshire County, from the data that you saw from Dr. Johnson. And here you can see that teenagers, in our community, who drove under the influence of cannabis is about 16%, and under alcohol, 5%. And these are of the 12th graders. Then if you look at cannabis, it's even, for cannabis, it's 16%, and alcohol is 5%. If you ask the question, have you been in a car where the driver had used the substance, not necessarily yourself, it's even higher. So obviously, these are very dangerous behaviors that we're seeing, and that's why we have a large incidence of driving while intoxicated in the teenage and young adult age group. So marijuana is not harmless for teens. In this culture now, in the past few years, marijuana has become legalized, and there are many places in our community where you can get marijuana as an adult. You have to be 21 for a reason. And I think that sometimes gives younger teenagers the idea that this isn't a very harmful or it's a safe type of substance. And we know that that's not the case for them. And there are many studies, which I will not delve into deeply, but these studies are good studies showing that heavy marijuana use in the teens increases their chance of addiction, as I mentioned, alters brain development, results in poor educational outcome. There's good data looking at twins, for example, and one twin used marijuana at a young age, another one did not, and you look at their educational outcome, you look at their IQ, it can affect IQ, and then they look at life satisfaction and achievement, and there's a decrease in those categories the younger you start this marijuana. Of course, smoking any kind of substance can result in chronic bronchitis or respiratory disease. And then there's a major correlation with schizophrenia, which is a very significant psychosis in those people who use marijuana at a young age. So there are many reasons for us not to have our teenagers use these substances. In our practice, we're also seeing something called marijuana hyperemesis syndrome, which is a syndrome associated with frequent use, and it results in teens coming in vomiting, having difficulty with nausea and abdominal pain. And a unique characteristic, if you ever hear anybody say that I've been vomiting a lot and then I go into the bathroom to take a warm shower and that's the only thing that really makes me feel comfortable, that's a hallmark for this syndrome. We also see teens who are trying to stop. Not all, in my practice, I can tell you they're like two separate groups of teenagers I talk to. Some are using marijuana sometimes regularly and feel that it's okay. They feel for one reason or another that it's not dangerous, and they don't seem to have sometimes an interest in stopping. And then there are a number of teens who are using marijuana and recognize that this is not something they want to be doing, and they try to reduce their use, and then they develop withdrawal symptoms such as restlessness, increased anxiety, irritability, falling asleep, decreased appetite, and weight loss. And what I'd like to say is that if this is happening to any of your children, we can help. We can help with with medications, can help with all of these symptoms. Things that Kit will talk about will help them as well. So obviously, if you're going through withdrawal symptoms, you might say, oh, I need this marijuana because it's been helping me prevent these things. But in reality, when you're stopping the marijuana, what's happening is you're having withdrawal symptoms. I'm going to very quickly just list these risks for vaping. Because of time, and I don't want to extend my time, vaping, in my experience, has been something that a few years ago was even higher than I'm seeing now. I think that finally people have understood that we didn't know what vaping caused and assumed, because it was marketed that way, that, oh, this is safe. And of course it's not. Vaping has different chemicals, nicotine a primary one. So you have nicotine addiction, and I see a fair number of teenagers in my practice who are addicted to nicotine because of vaping. There are other chemicals that are harmful to your lungs, glycerin, propylene glycol, and those can cause something called EVALI, which is electric and vape associated lung injury, which is a very serious disease that can lead people to the hospital or even death. There are good studies showing that vaping can lead to future cigarette and marijuana use. So this is not the safe thing that some people had purported it to be early on. So in conclusion, I just want people to remember that the adolescent brain is not fully developed, that the rewards pathway is highly sensitive during adolescence and increasing susceptibility to addiction, and that substance use during adolescence can change the developing brain and increase learning, memory, and mental health problems. There's one more thing I want. So what do we do? I'm going to turn this over to Kit in 1 second. I just wanted to explain what we at NAP have available for your patients. we are part of a number of practices in the state now that have rapid access and availability of people who are trained to help teens who are using substances. So we actually have a clinical social worker, Kate Boyer now, who's in our primary care setting, who is trained to help these adolescents reduce or eliminate the substance use. And what's really important to know is, one, it doesn't have to be a substance use disorder. It's any substances at any amount. And two, the idea of our program is that it's done in the medical home. In other words, it used to be that people would, if somebody came to my practice, said they were using substances and they needed help, I would say, give them the number and say, okay, go over there or go over there, to people who I may or may not know, but we didn't know how to deal with it ourselves. So we had to refer them out. But now it can be done in the medical home, just like just about any other medical problem that I see. And I think that that helps our teens and maybe our families feel more comfortable knowing the people who are around them, knowing that this is something that's common, and knowing that it's something that people who they see for other things like well checkups or earaches or whatever can help them with this problem. We do medication assisted treatment for even opioids, as well as alcohol, cannabis, and nicotine use disorders. And if you want, I can get into how we do that, but the idea today is to give you a general idea of what it is we can offer. And as far as treatment, I want people to know we have individual counseling. I don't think right now, Kit, you correct me if I'm wrong, we're doing any groups, but I'd like to see us do some groups at some point. And what's very important is that we give parent and caregiver guidance. I mean, it's not uncommon that the teen themselves are not interested in getting help, but you as a parent can receive help from Kit in particular on how to help your teen. And I think she's going to then give us a more detailed idea of how that's done. So I will, are there any questions about what I've said so far?
I actually have a question.
Yes.
Thank you for doing this, by the way. I'm really happy to be here. Sorry, that's my dog.
Yeah.
I'm curious if, I know that we're talking about substance abuse, and my kids, you know, so far have not been introduced or have ventured into that area, but with gaming on the screens, everything you're saying sounds like it could be interchangeable almost. I mean, is that, so I know I'm veering off a little bit because I know that you guys do talks on you know, screen addiction, but I just, it's triggering the same type of addictive neurons. Is that right?
So yes, and a little no.
Okay.
Addiction is often centered around the nucleus accumbens. So I believe that, and I'm not a substance use, I don't have a fellowship degree in substance use, but I do see a lot of patients with it. And so I think I have an understanding of how addiction occurs. So what you're describing is not a substance, but an addiction nonetheless. So the idea of this, what happens is with addiction is that part of the brain gets stimulated and stimulated and stimulated during this period of time when it's developing, and they don't have necessarily the prefrontal cortex or the ability to reduce that or think, oh, if I spend 10 hours a day or whatever on screens, it's going to affect me in my school or my development of the brain, because it can. So there are definitely a lot of similarities. Some are not, in the sense of what withdrawal and tolerance and all that stuff with every particular substance, like lung disease or what have you. But I think in general, you're absolutely right. It's a good correlation that addiction is addiction and that it needs to be addressed, and that if your child is addicted to gaming or gaming more than they should be, I think that we can give help for that. It may not be Kit per se, but it would be somebody else in my office.
That would be great. And would that go through me and then to my children, or would I bring my kids into that? My 13 and 15-year-old?
Right. So I would start by talking to your primary care doctor and provider, and it probably would start as teenagers. We usually do them, parents are always involved, yes. The younger kids, and Kit, you're probably better telling me about this than answering this than I do, because you're doing that work. But I think the younger kids, often it starts out with the parents, giving an idea of what's going on and giving you ideas on how to limit these and help them with addiction. And as they get older into the teenagehood, it gets more into the parents. Is that right, Kit? Can you comment on that?
Yeah, you said that well, Dr. Schwab. It really depends on the family and the young person, what would be best if if you as a parent have questions there. Myself and the other IBH clinicians can provide parent guidance and or do one-on-one counseling with your young person.
Great. Thank you, guys. Thank you so much.
Sure. So Kit, why don't you give us some ideas on what it is that you do to help these teenagers?
Sure. Let me get my slides up quickly. Let's see. Can you guys see this okay?
Yes.
Okay.
I can.
Great. So I am Kit. I'm a licensed social worker and behavioral health clinician. As Dr. Schwab mentioned, I work for Boston Children's Hospital in their Adolescent Substance Use and Addiction program. And I'm housed in the office at NAP. So I work with the primary care providers and nursing staff and other behavioral health clinicians in the practice. I thought today that I would talk about, I think of as putting tools in your toolkit to help support, to help support you and your family and the young people in your life that you're worried about or are using substances. So the first tool is understanding substance use in adolescence, which Dr. Schwab and Dr. Johnson talked about, having neurobiology and the data about what the risks are of young people using substances and how, what in our area, what substances are being used and by what age groups. That information is so important because that can not only hopefully empower you to make decisions to support your child and support them in making healthy and safe choices, but also allows you the information, gives you the information to educate your children about the substances use in the area and what the risks are. And that might seem a little too simple, but it's really important because in our area, there are so many dispensaries around, and a lot of the talk on social media and amongst adults is that using, for example, cannabis is safe because it helps with sleep and anxiety, and that's just not the case for our young people. So having this information is really important. The other is limit setting, and I'll get into these in a little bit greater detail in the next few slides. But limit setting for our young people, teenagers are in this period of identity formation and are programmed to want to explore their environments. And so setting limits creates boundaries that can help them feel safe during this exploration period. Thinking about setting limits is talking about what your house rules are around substance use and reminding them, talking about that, what those rules are. That's often one that sometimes we can assume our young people know, oh, I know my child knows not to use alcohol, but talking about it and talking about the risks and letting them know how you feel about it and setting those limits is really important. And in doing this creates expectedness and predictability, which during this period of uncertainty for teenagers is really, really important. The next is the behavioral contract, which I'll talk in more detail This is a really helpful tool in supporting your young person who's in abstinence or recovery process. Like limit setting, it provides expectations and a framework around how to support your child in their abstinence and in the recovery process. And also, like limit setting is creates predictable structure, which for our young people, when there's so much uncertainty in the teenage years, physically and socially, developmentally, having that predictability can really be a solid foundation. The next point I'll talk a little bit more about in a few slides is communication. Again, seems like maybe a little bit too simple. Of course, I talk to my young person, but this is such a vital tool, and I'll talk about some really great communication strategies so that that you can use, and also teach your teens and children about, so that both you and your child can feel heard and seen. At the end of the day, as humans, I like to think that we all want to be seen by the people in our lives, and communicating well and often can be a really great way to show that. And the next point is the tool, and the toolkit is self-care. Self-care, I know in the past several years is become this buzzword and maybe a little bit too, maybe overused. And I'm guilty of making up that at times myself, but self-care is truly so important for you as a caregiver. Taking time to do something that makes you happy, makes you feel fulfilled, makes you smile, and those can be little things. Sitting in the sun for a couple minutes, or taking an extra long shower, or getting your favorite coffee. But taking care of yourself is the best way that you can take care of the young people in your life. So that is something that can be really hard to do, and really important tool to have. So this brings us into supporting your adolescent, and I laid out what we think of as the different processes of use and recovery. So we have active use, abstinence, which we think of as between 0 and 3 months, early recovery, which we think of as between 3 and 6 months, and ongoing recovery, 6 months or more. So active use, this is a time when you might get your PCP involved. Either that's making an appointment to talk with them yourself, or that's something that maybe you and your young person have talked about and wanting to go to your PCP for support. And then sometimes what can happen is your PCP will make a referral to meet with myself or one of our other behavioral health clinicians. But since my focus is around substance use, it would probably be myself. And in this, and again, a referral or talking to your PCP or myself can be at any point that you feel you need a little extra support. It doesn't have to be at a certain time. We're here for you when you have questions or need some guidance. But in the active use, when your child is evaluated for treatment, usually I would meet with, if I get a referral, I meet with, depending on the referral, meet with the patient one-on-one and do an assessment, which is learning a little bit about them, what their interests are, what their stressors in their life are, trying to learn a little bit more about their substance use and frequency of use, and trying to understand why, what's that root cause of why they're using, and that then coming up with a treatment plan. And that, well, really what that means is deciding, depending on how often they're using or what the needs are, and the acuity of their mental health needs, figuring out, is this something we're going to meet weekly, every other week, once a month, check in, once every other month. It really varies by the patient. Some in treatment, thinking of like other mental health issues, there's some therapies that are really effective Cognitive behavioral therapy, or CBT, as it is most frequently used, is a way of helping patients recognize, avoid, and cope with situations that might be times when they're using drugs, using substances, when there's a feeling of anxiety and they don't know what to do with that feeling, but they've learned that smoking cannabis makes that feeling go away. So helping them learn about that, learning about what those feelings are, and trying to change some of those behaviors. Motivational interviewing is also a great therapy for young people who are using substances, and that's focused around the patient's readiness to change their behavior when it comes to substance use. Are they ready to quit vaping, or is this something that right now they don't have the coping strategies to navigate those feelings without the substance? And then so I got away with myself here on active use, but thinking about abstinence, I'll go into another slide in just a second. The lockdown phase. This is a really critical phase in supporting your child. The purpose of the lockdown phase, maybe this is, you just learned that your young person is using, is to remove the, yes, locking down, taking away car, cell phone, cash is, setting limits and showing what consequences are for breaking rules. But it's also a way to remove triggers and stimuli for cravings that keeping the amygdala from lighting up as much as possible. So maybe it's social media, taking away the cell phone, where they have access to Snapchat, where they're seeing images of substances or their friends using, or able to reach out to strangers and get access to substances. Early recovery, I'll talk in another slide about what I had mentioned before about behavioral expectations, but coming up with expectations for your young person. And, if they're showing that they're meeting your expectations and not using, beginning to loosen some of those restrictions a little bit. And then ongoing recovery, gradually removing more restrictions and negotiating more responsibilities and privileges back for them, giving them a little bit more independence. In looking at this chart, I think it's really important to consider that, like the management of other chronic diseases, treatment for substance use is a process. I wish that we could, it didn't have to be that way, but that is, it is a brain disease, substance use disorder, and that can take a long time to create change, but it can be treated with the appropriate supports and therapies. It's also important to consider that, like the treatment of a chronic disease, there might be a slip in the recovery process where your young person is in early recovery, they haven't been using cannabis, and they are with their friend and they're triggered by something and they use. And I say slip because I think it's a little bit more gentle term, a little bit less shaming, and discrediting of the young person's motivation and energy that it takes to not use substances. But it's those slips happen, and thinking about anything else that we're trying to do. You're trying to get the perfect score on a grade. You might have a test or two where you don't, or slips happen in recovery, in substance use, and in other areas of our life. So something to consider. And then this is what I had mentioned about the lockdown phase, and showing on this was a slide, a study where, and these are two images of brain scans, where the subjects watched a nature video and then another video showing drug paraphernalia. And as you can see in the drug video, the yellow area on the upper part of that image is the amygdala, where the brain limbic system is, Dr. Schwab, I hope I'm doing an okay job here. And that is where the cravings occur. So seeing those images, the amygdala becomes active and the craving is triggered. And so when you think about the lockdown phase, taking away triggers and stimuli to prevent the amygdala from lighting up. And I show this image because it's really powerful to see a brain that saw nature videos and a brain that saw images of drug use, and how lit up that is, how strong that craving is. So the 7 C's, this is a great strategy to use in the lockdown phase, or can be used in, it doesn't have to, you don't have to think about it necessarily in that chart that I showed you, but can be a helpful tool in taking away triggers and stimuli for substance use. So the 7 C's are restrict cash and credit card flow, suspend card privileges, limit cell phone use, monitor computer use, and adjust curfew. Thinking about restricting cash and credit card flow. A lot of our teens might have jobs or get money from family members and are able to buy substances at school through social media from strangers. So taking away access to cash, or offering to give them a certain amount of cash and then asking for receipts for the cash that you gave them, or thinking about having a joint bank account for a credit card so that you can see what their transactions are. And then suspending card privileges. This is a big safety one for young people that are using substances, taking away the car. So there's no use of car. I know I live up in the hill town, so I know it's hard to, going to school or going to a doctor's appointment. It's a long distance, and it can be really a sense of, oh, sorry.
I think we might have lost your connection there, or was it mine? I think.
Was it mine?
Well, I hear you now.
Okay.
I think so. It seems better
I'm
now.
back. Okay, I'm sorry about that. Did you hear what I mentioned about the car privileges?
I think so. Yes. I think it's, yeah, you just went out again. So go right at.
Shoot, I'm sorry about that. Let me know if it happens again.
Will do. I think you're good now.
Okay. For car, you can limit, saying only for doctor's appointments, only for school, and then limiting cell phone use. I know that cell phones are a huge part of our young people's lives and can also be for safety as well. But that's also a great way for them to get access to substances. So thinking about limiting cell phone use, maybe that's no phone at all. Maybe that's asking for them to put GPS tracking on. Maybe it's limiting the phone to just being in school, or not in school, just at home, or saying no phone at bedtime, no social media. And kind of similar to the cell phone is monitoring computer use. And also adjusting curfew if they have a late curfew, maybe changing that so they're coming home during more daylight hours, or not staying out so late on the weekends. And then we move into what I had mentioned before about behavioral expectations contract. I'll go over a couple points of the contract, and then I'll show you an example. So the first thing to consider if you're in coming up with a behavioral expectations contract, and again, it's going to be a really helpful tool to use when you have found out that your young person is using, is thinking of 5 areas to focus on. Because once you start, there might be many areas that you would like to have behavioral expectations around, but that can get a little overwhelming and punitive. So focus on 5. And try to make sure those areas are measurable, so that you and your young person know when there is progress. And also in the contract, thinking about making sure that it's really clear what the expectations are, what the rewards are for meeting those expectations, so there's no ambiguity. And different rewards and consequences for each of the 5 areas if you choose 5, because that can really help with motivation if they're different areas for rewards versus trying to work towards the same reward in 5 different areas can be a little exhausting and also not as motivating. And having the contract, thinking that it's going to promising and thinking about evaluating, maybe setting up different points where you sit down and talk about the progress. And kind of along the same lines, coming up with a timeline for evaluation. We'll put this contract in place maybe for a month, and then we'll sit down as a family and evaluate the progress. Or we'll try this for a week and we'll evaluate the progress. So this is an example of a contract. One thing to think about if you do decide to create a contract is actually writing it out. That's a really great way to make sure that it's clear and there's no confusion about what the expectations are and what the goals are.
Okay, can I ask you a question about this?
So
Because
that neither you nor your young person can argue that. Sure.
Yeah, I think this is something that you would do with the parents. We're not really we don't think that parents would be able to come up with all these things on their own, right? Or is this something that you think parents could be able to do? It seems challenging to me.
Good question, both. Sometimes I will have parent guidance sessions with parents and I'll introduce the contract and show them this slide and talk a little bit about what they can do. And then parents feel empowered to go home and try that out on their own. And other times sitting down with parents and helping them create what some of the areas are. But one of the important parts of the contract is the parents and their child sitting down together at some point so that there's a sense of agreement, that it's shared, that it's both the young person and the parents working on this together. So I might help parents think about some of the different areas or expectations, and then encourage them to talk about that with their young person on their own. So kind of like thinking about how the treatment plan varies by patient. This also kind of varies by family. But I would always be happy to talk about this, helping a family with a contract or even facilitating. I haven't yet, but facilitating a session with parents and their young person in developing the contract.
Thank you.
Yeah, it's a good question. So I won't go over all of them because I know we're getting close to end of our time and I want to make sure we can hear questions, but we'll just take a look at the grades. The goal is to maintain a B or better in every class, meet expectations for every B, or better, you earn 2 hours of time with friends each week, maximum of 10 hours. And in the language, you'll see that it's really clear what the expectation is. And then does not meet expectations for every grade below a B, you lose 2 hours of time with friends. So again, being really clear about what can be given and what can be taken away. So then moving to communication. So one of the things that I'll talk about, I have a slide for, is family meetings. In thinking about, and this is something that can be done whether your young person is using or is in the recovery process, setting up designated times for family meetings, once a week, once every 2 weeks, and focusing that time around talking about some of the difficult issues. Maybe that's talking about the behavioral contract, or maybe that's talking about asking them, checking in, how are things going with your recovery process. And containing these conversations to specific times, so that, because as a parent, it can be, thinking about your concern and you're worried about your young person using substances, and it might be something that you want to check in on all the time, and want to ask how things are going all the time, and that can be really overwhelming for adolescents. And giving them a certain time, like a family meeting, that they know they're going to have to talk about some of the hard issues, can create a safe environment to have some of those hard conversations. Being for them to be able to plan for it can be really helpful, and for you as well. It also creates more space to have conversations that are not focused around the difficult issues, that are focused around their successes, or things that they enjoy. And family meetings, it doesn't have to be formal, sitting down across from each other at the dinner table. It can be, let's go have our family meeting and get some ice cream, or let's go take a drive, or, so, it can be fun, it can be different, but time together, and knowing when that time together is going to be, and that there might be hard conversations, is helpful. And then some great strategies to help with communication are stop, reflective listening, and I statements. Stop is exactly as it sounds. You might be in a conversation with your young person and they say something that just gets you really fired up and you want to just respond right back. And if you notice in your body that there's this sense of, that maybe you're feeling a little bit stressed or a little bit frustrated, it's okay to stop and just take a deep breath and give yourself a second to think about, okay, how do I want to respond to this? How can I respond to this? So that you're coming from and thinking about what your options are, so that you're coming from a place that's a little bit more grounded than immediately reacting, and then going forward. Think about what your options are and respond and keep going in the conversation. The other helpful tool is reflective listening. This is a great one that involves you and your young person. Maybe your young person, you're explaining what your concern is, and your young person is listening, or your young person is explaining what their concern is about not being able to use cannabis, and you're listening. And then when they're done explaining, you reflect back what you heard. So you can ask questions like, are you finished? Or let me see if I got this straight. And sometimes it can be helpful to summarize. You can say things, for an example, it sounds like what you're saying is cannabis is helping you sleep. Or I think what I heard you say is, and this strategy is a great one because it really helps the other person feel like they're being heard. And as I mentioned in the beginning, being heard is being seen. And so when someone can reflect back what your concern is, it can be really powerful to the person who's was expressing that. That's just another example. And then I statements. I statements are also wonderful because it really, when a person feels they're being blamed, it's really common that they respond with defensiveness, and it's really, really powerful to tell someone your emotion versus critique something of them. It's really hard to argue someone's emotion and feeling than it is to, it's really easy to argue something that they might be saying about yourself or your behaviors. So this is just a little, example here. So an I statement is I feel, and inserting an emotion because with an explanation. So in thinking about, your young person is using, I keep going to cannabis, but has been using cannabis and maybe was out late the night before. Instead of saying, you were out late and you came home and you made me scared, taking that, naming that emotion. I feel scared when you come home late or when you come home high because I love you and I worry about where you've been. Or I feel worried when you don't answer your phone because I don't know where you are when it's past curfew. And that can be, both I statements and reflective listening. It is something that you don't have to necessarily use in conversations just around substance use, but can be great communication strategies in any communication that you have with your young person. It's modeling healthy communication. It's modeling acknowledging other people's feelings and concerns. And communication is such an important, as we know, life skill, and being able to talk about some of the hard emotions or feelings that you're having, that can be really hard to do. And so modeling what that is like in different ways to talk about that can be really helpful. And again, this is something that you can use and talk about with your family, or things that I often talk with the patients that I meet with about helpful ways to talk with their parents or the people in their lives is using I statements and reflective listening, because it really changes, kind of slows down the momentum of a conversation, and really helps people be present in hearing what people are saying and how they're feeling. And so again, modeling healthy communication and using some of these strategies, in thinking about I statements and or reflective listening and letting your teen be the expert in what they're talking about. And to summarize the kind of the last couple points, because I'm realizing we're getting close on time, is really being present in the communication that you have with your teen, whether that's around conversations related to substance use or talking about how their sports practice was. Don't pick up your phone, or as tempting as it may be, maybe turn the TV off, put the papers down, make eye contact, and in doing that is modeling how you want them to communicate with you as well. And these are the slide about the family meetings that I had mentioned, but I'm just gonna skip past that, and we're gonna go to my question slide because we only have so much time left.
Thank you, Kit.
So I will leave it at that. Sorry that I didn't get to. Yeah, you're welcome. Let me end the screen share here.
Does anybody have any questions for Kit about the kinds of work that she does with families and teens about this issue and how she structures that?
I don't have any questions, but that was really informative and helpful. So thank you so much.
You're welcome. I'm glad to hear that.
One thing I wanted to emphasize again is that at NAP, what we do is we use Kit and use her expertise for any teen who is using a substance, not somebody who necessarily has a substance use disorder. And it is very common for me in my practice to see what we call comorbidities. It's people who are kids, teenagers, and adults who are using substances, but you also have anxiety, depression, sleep difficulties, ADHD, and they may even be thinking that this is in some ways treating those diseases, those ailments. And so it doesn't mean that they have a substance use disorder, But if I see a patient who is anxious, has anxiety, and could benefit from some help with that, and is using substance in some form for one reason or another, I can refer them to KIT, and KIT can help them with the anxiety and also help them with this substance use and help them understand and hopefully decrease and eliminate the use of the substance, because it's not helping with whatever that comorbidity is. I'd like to also say one other thing is that what I didn't get into, and I won't, is that often people who use substances, teens in particular, will have symptoms, as I mentioned, of withdrawal or anxiety or depression like that. And what we, in that, if that anxiety is not being appropriately treated, such as through either therapy and or anxiety medicines, which I can get involved with, then that substance use may be difficult to stop. So there are other things that we can do medication-wise to help with teens who are using substances, either to treat a comorbidity or actually to help reduce the cravings. There's nicotine replacement. There is medication called NAC, which is helpful for cravings associated with THC, which is the active ingredient of marijuana. There are medications for alcohol use, naltrexone, for example. And then there's, of course, opioid medications that can be, that is Suboxone, which can be used to treat opioid use disorders. But so I want to know that that's what our idea at NAP is, to kind of do all this under one roof. Now, we can stop the recording if you like, and I just wanted to certainly give people an opportunity to ask any questions that they might have of any of us about our presentation or anything that may be related.
A question.